Well, welcome everyone to our continued weekly town hall based on COVID-19 and other related topics. We are proud this evening to have Starlett Hayden-Greeting, our Director of Clinical Programs and Population Health, present our evening's topic on telehealth. And I will switch it over to Starlett.
Okay, so I got it. Can you hear me?
We can, and you're good to go.
All right. So I've been doing some research with all the other pharmacy organizations about our ability to provide telehealth, telemedicine, telepharmacy, telephonic interactions for comprehensive medication management, which is the global term for the subgroup of MTM Part D. Many people are already providing some of this because you're already a telepharmacy and you have audiovisual interactions. So I have nothing to disclose. The only conflict I have is that I eat, breathe, and defecate pharmacy. All right, so tonight we're going to talk about, we're going to try to describe some concepts of population health. Whether you know it or not, you are involved in that. Discuss a little bit of our current legislation during the COVID-19. List some ways that you can map your workflows so you can utilize telephonic communication with your patients to maintain patient service, and outline some tips and tricks. We're not going to get in, it's only 15 minutes, so we're not going to get into any of the, dig into the details. If we need to, that can be a CE program going forward. Here's your pre-test. When were Illinois pharmacists given the ability to be included in telehealth services? So 1990, 2015, 2018, or 2019. Second is a true or false. During COVID-19, the CMS 1135 waiver includes pharmacists as clinical staff for telehealth fee-for-service delivery. True or false? Okay, so what is population health? So when you think of population health, I just remembered 35 years ago when I decided to work to become a pharmacoepidemiologist, and everybody else was getting their PharmD. They were like, why do you want to do population health? Well, population health is a study of what the population is doing, and you can start high, like the entire world, and then down to a country. And for the United States, our population health is for our country. And then you can narrow it even more down into groups of individuals, and which would be kind of at the state level or community level or county level, your county public health department. And then for those of us in healthcare, we have our individual patients. And within our patients, we might narrow that down to the patients with diabetes, or patients with migraines, or patients positive to COVID. So when we talk about population health, we have to talk about social determinants of health. And if you don't know what social determinants of health are, we're seeing the results of where we live, how we live, where we go to church, where we work, where we play, on the impact of what COVID has had on our population. So if you live in a 12-story apartment building and only have 2 elevators, your ability to protect yourself with social distancing is somewhat more reserved because you're in a cramped space. Whereas if you're out in a rural area where it's 2 or 3 or 5 miles to the next house, then you're a little more spread out. Both of those the concentrated population and the spread out population are both impacted by social determinants of health. In the rural area, your bandwidth is not as fast, and so it may, if you get 4 or 5 people on the same internet connection, then it's really slow and you can't do things, or you may not even have a cell tower near you to where you can use your cell phone. Whereas in the urban areas where it's concentrated, they have a higher bandwidth, they put more boosters out, and you have that ability. However, there's just as many consequences of living in a short urban area, close-knit urban area, than it is out in the rural area. So you can see that when Garth shows you some of the maps where we've had an impact of COVID and how it's been passed. Right now, our nursing homes are quite impacted by the COVID because they're living in a congested dormitory area where they have healthcare providers coming in and out of the nursing home, but we're still trying to figure out how it got there. We're still tracing the facts. We can't quite figure out why a nursing home in the middle of nowhere is being hit, and it's probably because we have some medical assistants that don't have any symptoms of the COVID, and don't have a fever and don't have any of the 6 new indications, are still feeling well and still delivering care, but our elderly patients are a little more susceptible to it. So someone asked earlier when we thought the nursing homes would open up and have visitors. Until they can figure out the contact tracing on our nursing home population or our assisted living or anything that has to do with our geriatric population, I think they're going to be off limits to some degree. Okay, so what is telehealth? So telehealth is kind of the umbrella terminology. This Center for Connected Health Policy is one of the best information sites. It was started by California a long time ago, and now they keep track of everything state by state. So if you want to know if your pharmacy's on a border, or you live on the border and you want to know what's happening in Missouri or Indiana or Tennessee or Wisconsin or Iowa, this is a place to find out what their government agencies are doing, what commercial insurance companies are doing. It's a one-stop shop, so I like to share that with you. It also goes through telehealth. There's a difference between telehealth. Telemedicine is something more geared around a physician or a primary care provider delivered service. And then all of us know what telepharmacy is. That's the special programming that we received in Illinois and across other states to allow us to have pharmacies in an underserved area where the pharmacist can stay at the main pharmacy and still have teleservices at an outlet pharmacy with a pharmacy tech. And that doesn't mix in with telehealth and telemedicine. That's its own separate group. And then also on the connected health, they are doing very excellent job on how each state is taking their 1135 waiver and applying it to their own state laws. So Garth and I check this. This is on our speed dial on our computer. So if there's something that's coming up, we check it. Sometimes we're faster than they are. They have to catch up to us on some of our new laws that are being put on, but this is an excellent choice especially if you're someone, we've got a lot of new practitioners who work in managed care, and they may work for an insurance company, and they may be going back and forth between different states doing telephonic MTM for Part D. And so this is an excellent resource for you to find that. Another excellent resource is the Telehealth Resource Center. So as you can see, each area has its own little regions. I like this map because I also want to tell you that we have regional MACs, which is Medicare account contractors who manage our our ability to bill Medicare. And so all these different colors, those are all the same locations of the regional max. And that's how, so CMS may make a rule and say pharmacists have the ability to provide, or HHS to do testing. And we have to look at all these different regions and get their regional max to let us bill Medicare for it. So, so we kind of hang in there with Indiana, Wisconsin, and Ohio. Ohio, Indiana, Michigan. Wisconsin's in their own, but we still check on what they're doing because it has an impact on us. So this is another resource for you. It always should have been. I mean, I guess since 2005, we kind of been wanting the ability to have expanded patient counseling services and get paid for it, MTM services and get paid for it. Medicare has not really allowed it. And because Medicare has had all these rules prior to March 1st, had all these rules, nobody really provided telehealth or virtual healthcare to very many patients on a Medicare basis. There are some cash programs out there. There's a lot of millennials like the Dial-A-Doc, so they can get their acute medicines through telephonic, but that's cash. So think about that for the future. Remember, Gar says there's no rules that say that you can't charge for counseling. So I represent the National Quality Forum as a pharmacist for the Pharmacy Association, and we do have a set of qualities. So the reason why I put this up here is that when you're trying to decide about your service, if you start getting more involved, and I think we are going to do more patient care through a telephonic or televisual process, where you want to be able to make sure that if you're improving the access of care for a patient, that's a star. If the financial impact and costs is neutral to the patient and we're able to reach more patients, that's a star. And we want to know what the patient's experience is like. Not just the patient's experience, but the care team member, your person that's providing that services, and then what the whole community is about. So when this all rolls forward, there will be quality measures for that telehealth. And then of course we want to know what the effectiveness is. Right now the IPHA patient self-management program is doing a telephonic delivery of diabetes education to our patients up in the city of Chicago. And so I've been using these domains to kind of watch how that's going. And when and if this is over, if we go back to face with them, we will probably survey them and ask some of these questions according to this quality parameters. Okay. Whenever you're developing a new service, you always want to try to create a performance circle. Well, and those in the academic world or those of us that are in the quality world know that we plan, do, study, and act. And this is a PDSA cycle. And so anytime it allows you and everybody that works with you to have input. And the easiest way, they have fancy tools for all this and expensive software that you can do workflow. But I've always used, and we do at the office, we manage by Post-it note. So when you're trying to plot out your workflow, because everybody on your team, your pharmacy techs, your clerks, your delivery people, the pharmacists, your students, everybody has a role. And if you plot out your workflow and everybody writes what they're doing on a Post-it note, and then you start lining it up like a fishbone. You know, the fish has a spine, and then there's little more spine, fish bones that come off the main spine. So if you lay that out that way, you can create a workflow map just using Post-it notes and get an idea of how many tasks are involved in delivering a counseling session, or and each MTM process would be able to be like that. But if you have these workflows and you have them written up and consolidated, then anybody who comes in and work can follow your work for it. And you ask lots of questions. This also gets your team involved. So pharmacy techs, what I used them, especially when I was at the hospital, I had them follow me around and write down every task I was doing so that we could plot that all out. We kind of do that for the IPHA annual meeting. Every single thing that you see us do at the annual meeting has a fishbone and an algorithm that says, okay, we're going to have breakfast here, and then we're going to do these 4 sessions, and then we're going to go to Jeopardy. So that we plot the same way, and we have and the different colors are you give each person a color, that way you know who's responsible for each area. So it's kind of a nice way to kind of lay it out, and it's not so overwhelming. If you told me, Starlin, sit down and type up a 5-page document, and Kim and you work it out for the annual meeting, I'd probably walk away from it, because that's a lot of work to sit there and type all that out. But oddly enough, when you take out a pad of Post-it notes, it makes a workflow process easier. The benefits, it defines your task, it narrows it in. You actually discuss things that could happen, that could be problem areas or gaps in care. So when you guys had to move from patients coming into your stores and then you had to go to curbside or had to go through the drive-through, you did some of this mentally, but I just wanted to give you an idea that you can track this out the same way on developing your telephone conversations as you reach out to your patients. So the University of Jefferson University, and they have a huge health system on the West Coast, or East Coast, sorry. Stanford's on the West Coast. Both of them did a study with patients, because they have telehealth. Their states reach out to people in the rural area, and they surveyed all their patients, and it was a survey of over 2,500 people. And I attended their webinar a couple weeks ago, and they had this myth and the Mythbusters, and I really liked it, so I'm borrowing it from them with a twist, with a Starlin twist. So the myth is, my patients don't want to talk to me over the phone. They only want to see me in person. Many want to see you in person, but if they can't see you in person, seeing you over the phone, hearing you over the phone, or are FaceTiming with you is better and is a quick check. If you have an elderly person and it's ice storm out and you still need to check on that person, then they feel better supported. So the folks that got these telephone calls from their doctor's offices and from their pharmacies and from the outpatient care clinics felt like they were getting more for their visits. One myth is it's not as good as in person, and I'm one of those people that thought that. You know, I've been fighting for 15 years for the in-person diabetes self-management program, but the COVID has taught me that my patients that I talk to, and the patients that are up in Chicago that need an extra support and call me, they appreciate having the safety of being able to stay at home and have their conversation with their pharmacist and have their conversation with us as a supporting diabetes program. You can't examine a patient. You can't examine the person, and that's not necessarily so. And I'm converted on that as well. We just gave our first virtual diabetes and cardiovascular certificate training program, and each person that took the training program had to have virtual skills assessment. So Dr. Kerr and Dr. Roselli and I split up all the participants, and we did Zoom, one-on-one Zooms, and they had to get someone to be their their patient, and we did their physical assessments and their teaching one-on-one, and it really worked well. We sent them blood pressure cuffs out and made sure that they had all the supplies. So with remote monitoring, which by the way is reimbursable, with remote monitoring, this gives you eyes, ears, and on-site to weigh them, to get their weight, to do their blood pressure, to check their pulse oximetry, and several other remote. Even the blood glucose meters now are Bluetooth, and they can upload those to their phone and then send them to you in your FaceTime or your Zoom appointment, or it can go straight. You can have a login to their login, and you can see their blood glucose. So we actually see more about the patient when they're in their own home. Even if you can only hear them, you can hear if they have a dog, and if they're complaining about allergies. Like I have all my families calling in and asking me if they have COVID, and every time I hear their animals in the background, I keep telling them that they're stuck in their house and they're having dander allergies. And so you can hear lots of information. Some of my patients, when we're doing diabetes, they FaceTime me when they're at the grocery store because they're nervous about picking out food. And so you can FaceTime, and when it's not, if it's their idea with their permission, they can show you that. You can see if what they have in their refrigerator. You can see what's in their pantry. So now that we're able to use FaceTime and Zoom and Skype, the government's kind of relaxed all that because they realize that not everybody has the high-end audio televisual technology that hospitals, large hospitals have. Even small hospitals don't have that. There's a lot of rural hospitals that aren't completely equipped with that. But now I think the cat's out of the bag, and so we're going to have those advantages. Another miss is we're not reimbursed yet for the same amount of money, and that is an issue. But what I said before, if you don't have a visit at all, there's no reimbursement. So even if the telephonic visit is half that as a live visit, at least you're making some connection. Now, this past week, Medicare made some changes for that for physicians, and they're matching their live visits. And pharmacists as auxiliary personnel can assist the physician in making those telephone calls if they have a contractual agreement. So we can talk more about that later. And then the myth is it's too hard. It really isn't, because in 2020, I mean, look what we're doing right now. We're having a Zoom meeting. There's a group of us that have been texting and have a group text going on. This is the only way I can talk to my kids and my grandkids. I have a portal. So it's not so hard anymore, and we're adapting to that. Again, I want to just review this. So when you're trying to create an encounter, you want to think about what everything you have to do before you're going to have a MTM or a comprehensive medication management encounter. So it's in 3 stages: a pre-encounter plan, which all that pre-encounter plan can be done with your techs or your students or your residents. Then you have the encounter, what the health professional is going to be doing during the patient call, and then post-encounter plan. So you've got to do the documentation, you have to follow up with your primary care physician, and so that is your plan. And then again, if you work diagram each one of your areas, then that helps your workflow, and everybody gets, you get a lead pharmacist and a lead technician, and you utilize all the support staff. I love Trip Logan did a poster session at the quality assurance meeting, and he turned all of his delivery people into community health workers, because Missouri has a certificate training program. It's like 6 hours, and then they're community health workers. And he has empowered his delivery folks to go and make an assessment of that person where they live, so they can see if they don't have enough food, or if nobody's mowed their yard, or, you know, you can tell how a person is living and what they need based on where they're at, and your delivery folks can do that. The clerks hear conversations that the patients don't really say at the pharmacy counter. So this allows you to empower them a little bit. And then you know, again, the appointment-based model helps you move to this telephonic process. Those of you that are in the Flip the Pharmacy, you're tracking this now, and the pharmacy e-care plans are an excellent way of doing that documentation and follow-up with the primary care. So just do's and don'ts when you start the call is create a positive environment around you, so that when you're in the call, you're not interrupted. So when you flow chart your area, make sure that you're not trying to do 5 things at one time. You can't check scripts, you can't reconcile, you can't take phone calls while you're on another phone call. So that has to be, the person who's doing those phone calls have to be marked out. Smile. So when I'm sad and I'm grumpy, I talk like this, right? But when I'm smiling, I smile, and my smile shows through even through the phone. And you all know to personalize it, and you personalize it how they like to be addressed. Some people like the Mrs. For me, when someone says Mrs. Greeting, I say that she doesn't live here, she's in Columbia. So for me, you would personalize it by saying, hey, Starlin, I want to talk to you about your new refill. You didn't get your refill and you got a new script. I need to talk to you about that. Set the stage, explain the purpose, ask permission. Those are your MI skills. Asking permission and using open-ended questions are the best MI skills that you should take away from a motivational interviewing process. Asking permission empowers the person you're talking to and shows respect. Pause for responses. It's okay to have some silence, not too long of a silence, because if it's too long of a silence, you might have to ask them, I need to repeat it? Did you understand what I needed to say? Maybe they were being disrupted on their end. And so it's okay to repeat all that. What's important is you can't, in a telephonic, you can't see their eyes, so you don't know if they're getting it all. You don't know if they're shaking their head. So you have to ask those open-ended questions, but also follow it up with, did you understand that? Do I need to repeat anything? So constant checking back and forth. Remember not to talk too fast. The older I get, the more I enunciate this. I know when we're trying to do quick programs, we're rambling through, but don't talk too fast, because if they're trying to understand what's going on, if they're hearing something, it goes faster than what you think that they are. And the older we get, the harder it is for us to slow 22-year-old people down. So the younger you are, the faster you talk, and the older you're talking to, you need to slow that down. So just be conscious of that. Again, don't ramble. I have a problem with that. So that's why I say do workflows and scripts, and that way you can stick to your script, and you'll get right to the points and right to the most important information, and you can take notes on that script. Again, don't be afraid of the silence, and don't forget to compensate for those nonverbal clues that we get when we're in person, because somebody will fold their arms up, or somebody, they'll look down, or they'll look bored, or they'll just shake their head as if they understand what's going on. That isn't necessarily what's going on. So when you're on the phone, you have to be that gentle, warm, inviting person that is letting the person give a response back to you, because you're not face to face. So again, start low tech, use those Post-it notes to plot out what you want to do. The expensive software is Visio. Telephonic it's not about the top technology, it's just another care delivery model, and I think we're going to get to keep it. I think we're going to have to fight. Pharmacists are going to have to fight for being part of that pie, that reimbursement pie, but we're there for you. Opportunities for improvement. So every time you do one, you'll figure out that the next time you do it, there's something you can improve on. So make a note on that so you can put that in the workflow. You sometimes get more information from them than you do in a face-to-face pharmacy visit. If they're buzzing through, they don't really have time, and they might have a toddler, or they might have somebody waiting in the car. Sometimes when you're on the phone with them, they'll actually give you a little more information. If you're worried about your time commitments, start with the shorter calls. We do have to counsel on patients with new prescriptions, so start with those. And then as you start developing a rapport, or you start developing a long-term medication therapy management process, then you can build into longer conversations and document that. Work with your primary care providers and find out if they need help contacting their patients, because if you have a contract with them, you can do those telephonic touch points, and they're between $24 and $44 Medicare dollars. I'm not always ask permission. May we talk about your prescriptions? And make it a family caregiver experience. So sometimes you can put you on the speakerphone if they're hard of hearing and they have a granddaughter or daughter or son that can be in there. And I have a little tip for you. I stole this from Southern California, Dan Kennedy. He sends, when he fills scripts and delivers them, he gives everybody an extra prescription bottle that has "Call Dan anytime" on the label. It has directions, and on the inside it has all of his social media accounts, any way, how to get a hold of him in an emergency, and he puts that in a prescription bottle, and he's the pharmacist in their medicine cabinet. I thought that was so awesome that I wanted to share that with you, because that would be something that you could do, so that when somebody goes, well, what's this bottle? And you say, well, that's me. You have your personal service care pharmacist right in your medicine cabinet. So I know you're exhausted. Everybody's doing everything telephonically. So I wanted to throw that in to be funny. And so here's the post-test. The year that Illinois pharmacists were given inclusion in the telehealth services was last year, 2019, in the Illinois Telehealth Act. And that was a silent but deadly one. So we were very, that the relationship that IPHA has with public health really fostered that, and they implemented it, didn't make a big deal out of it, and so nobody went against us. So during COVID-19, CMS 1135 waiver includes pharmacists as clinical staff for telehealth fee for service delivery. False. Pharmacists and nurses, RNs, are not considered clinical staff. We are auxiliary personnel. We can make those calls. There has to be a contractual agreement between the primary care physician, because he's going to bill fee for service. And so if you contract with him to do those calls for him, to touch base with his patients, he can reimburse you for doing those calls. Any questions?
Thank you, Starlin. Do we have any questions? Either you can put them into the chat box, or you can, again, go into the participant tab and hit raise your hand, and we can open up your line so you can ask Starlin a question. Laura, you are unmuted. Go right ahead.
Hey everyone, thanks for joining again. Garth, can you just remind us, and Starlin, pharmacists, I was a little confused by the first poll question, because pharmacists have been able, we've been able to do telepharmacy, which includes counseling, but this next level of medication therapy management is what we're trying to advance kind of above and beyond that. Because we've had telepharmacy for how long? A long time, right?
We've had telepharmacy since 2007, And a lot of the aspects of telehealth were around that same time frame, and we've kind of danced on the gray area between the two terms because we kind of always meshed them together. And when we were approached in 2019 by Representative Belloc's office and the Department of Public Health about inclusion in the Act, just to clarify that pharmacists could do telehealth, because we already had pharmacists doing it. So we just went ahead and got it put into the state law so that it is clear that pharmacists can do, and therefore we can bill for telehealth.
Correct.
Let's see here. Any other questions? Again, type your questions in, or you can raise your hand and I can unmute your line. Okay, I want to pause the recording for a moment so I can put up the code here. All right, we've resumed recording. So again, thank you, Starlin, very much for providing that update on telehealth and how that relates to our current situation. As we've always started these, I just want to remind everyone again that this meeting is for you. And as always, we're very good about making sure that we mute our microphones as we go through this. Again, raise your hand in that participant function and we can unmute your line. We do have the chat function, and every question is valid. And again, this is your time, so we can have an open discussion. So I do want to go ahead and proceed to some of our quick updates that we've been providing every week. Let's see here. So as we can, oops, let's see here. Okay, as we can see here, the United States now has hit over 1 million cases. We are now 1/3 of the cases globally. The globe, we reached earlier this week, we hit the 3 million mark on cases, and it wasn't too long after that that we reached over into the 1 million mark. We now have had over 60,000 deaths, and to kind of put that in perspective, NPR had a good article yesterday showing that we've now exceeded the number of U.S. casualties from the Vietnam conflict. So just kind of put that into perspective, but also think about some of the worst years of what we've had from influenza in the past and other disease outbreaks, and we're starting to get into the higher list where there's not a lot above COVID at this point. So this is still definitely having a severe impact, especially for when we encounter patients or even our own peers who still have questions about the true impact of this infection and disease and its impact on our country and our globe. Let's take a look again on an Illinois basis. As you see here, the Illinois dashboard, they have updated, instead of having the numbers here, they've used a color gradient. The darker the county, the more the cases. And as you see, the fully white counties are, and there's only 6 left. There's only 6 counties that have not had at least 1 case in Illinois so far. And we know that there are a lot of number of cases that are continuing to expand. We had 2,200 cases today, 2,233 new cases today and 88 new deaths. So we're at 50,000 total cases for the state. And we are now at 2,200 total deaths. We are still, unfortunately, not peaking yet. As you can see on our confirmed cases over here on the side, the curve is not spiking, but it's definitely not flattening out completely yet. So least some of the new data that's coming out is showing that we should be starting to flatten out, hopefully by May 15th or a little bit later, which is, as we'll talk about here in a moment, why the governor decided to extend the stay-at-home order. When we look at the social distancing data, Illinois is at a D as compared to the country, and this is kind of expected. If you remember, this is based on cell phone data, and you know, with the nice weather we've had over the beginning of the week and the weekend, you see like Saginaw County's at an F, and so a lot of counties, even Chicago's at a C- now. And again, that goes back, as we've said, a lot of people starting to wear as we continue the extension of the stay-at-home orders and just want to get out. And this is definitely showing some of that societal resistance. If you recall, last week we talked about how the Illinois Workers' Compensation Commission put in an emergency rule in relation to COVID-19 that basically stated that the business was responsible for any employee that contracted COVID-19. And the way the rule read, it didn't really state whether or not that the employee had to catch it at the workplace, which would go against all other facets of how workers' compensation rules are determined in determining where an injury of an employee occurs. So if you would look at what the cost would be, it would be a cost of up to almost $2 million per employee that they became COVID positive and they filed a workers' comp complaint. That would be the charge that the business would have per employee. And luckily, due to a restraining order that was filed by the Illinois Manufacturers Association and IRMA late last week, the Illinois Workers' Compensation Commission on Monday repealed the emergency rule, and which is good because, again, this was something that was pushed through very quickly in the emergency rules process and did not even have an open public hearing. And that's where some of the basis for pushing back on this rule at this time. And not saying that there cannot be a future rule on COVID-19 in relation to workers' comp, but it does need to go through the traditional rulemaking process. And then last Thursday, the governor did announce that starting May 1, that we would have an extension of the stay-at-home order until May 30th. And it does open up different aspects, whether it's outdoor recreation, some new essential businesses are named. Some non-essential businesses can open to take care of telephone and online orders that can be picked up outside the store, curbside. Some new essential, businesses and manufacturers are required to provide face coverings to all employees. So that's one thing to take a look at in your pharmacy. So if you're not providing face coverings for your employees or making sure that they have ample supply of them, you need to do that before May 1st. And also on May 1st, any individual coming into your pharmacy should, again, where it says any public place where they cannot maintain a 6-foot social distance, and that could be a lot of our own pharmacies and our practices, must have a facial covering. I do want to applaud, and I know there's a couple of questions I see popping up. I do want to applaud in advance a lot of pharmacies that I've seen on social media already stating that you're going to require facial coverings regardless for anyone entering your pharmacy, and I think that's wonderful. Hopefully most of you have gone to curbside delivery and you're going to be minimizing that. But again, please do make sure that face coverings are available for everyone. And let me open this back, take the sharing down so I can see your questions here. Does anyone, now that we're at your time, does anyone have any questions? And please, again, type them into the chat, or we can raise your hand and I can unmute your line. we've got a little over 10, 12 minutes, but we'll take as much time as we need to answer your questions. Oh, Rupesh, I see you visually raising your hand. Let me go ahead and come down there and unmute your line there. Go right ahead, Rupesh.
Yeah, with this DIR bill that 115 congressmen have signed and sent it to Pelosi, do we have any plan on reaching out to Chairman Frank Pallone in putting more pressure on how we can push that bill through?
Really, the pressure is one thing. Good thing that you bring that up. There is yet another effort by our federal congressmen, or actually just by general advocacy, of trying to address DIR fees again on a federal level, especially during the COVID crisis. We already knew that DIR fees already had a damaging impact on pharmacies, and COVID made this even worse. And we're glad to see that we've had a number of our representatives in our congressional delegation sign on to this letter. I believe we have 6 or 7 of them sign on of the 18. So with that, we need to see more of our congressmen on there, and we need to push back, especially because I know we had Congressman Shimkus, Boss, LaHood, Rodney Davis, I believe Bobby Rush, and Christian Northey, and who else am I missing? Is there anyone else that signed on? But if you've got Kasten, Kelly, Bustos, Lipinski did sign on. Again, we need to get these others, and Schakowsky, we need to get them on this supporting of moving this DIR bill across and getting it added into the next package. I think the biggest issue right now is whether or not Congress is going to meet. There seems to be a lot of grandstanding going on about whether Congress is going to meet or if they're going to be pushed off another week. So hopefully we can see some movement in the House. I'm concerned about it, even if it gets out of the House, whether it will be even considered in the Senate. The Senate has been a lot larger fight when it comes to financial issues on healthcare and specifically in pharmacy. And even if we get it through the House and we get it through the Senate, if it maintains in those negotiations, I think one of our biggest battles is going to be the White House. We know that Grogan, who is the domestic policy advisor, continues to be against us on the IR fee. And I'm not sure if that's because of PBM influence, but I would assume it is. And he definitely has the pull of the earlobes of the president. And as long as Grogan is still saying no, there is little doubt that we will see relief on DIR fees. And so, again, this may be a time also that we may want to be advocating directly to the White House as possible, as much as we can. It's harder in this administration to advocate to the White House as it's been in previous White Houses. But again, we want to make sure that we're continuing to press all of our congressmen in making sure that they are supporting us in this effort. Because the DIR fees, if we can't get this now, it's going to be even harder later on. As we get out of COVID-19, the government is more than likely not going to want to reform a lot when it comes to healthcare financial-wise after this, as much money as they've thrown at it over the last couple of months. So we've got to make this stand now and make sure we can get these changes in now. Some of the comments and questions here. With New York pharmacists going to be able to test, does anyone know how the reimbursement works yet? No, and that bothers me because there's not a lot of information about that. I do hope that the New York pharmacists made a deal with Governor Cuomo to do the testing, since he's so proud of his independent pharmacies now, that he was happily able to throw them under the bus in the 11th hour when he vetoed the PBM reform bill. And now independent pharmacies are who he needs to help the state out. So I hope that there was a discussion about that. What percentage of COVID deaths in Illinois are from nursing homes? Tom, that's a great question, and we'll have to look that up. I know that there has been a lot of discussion at the press conferences recently about COVID-19 in nursing homes, and there is a significant, I want to say, don't quote me on this, but I want to say it was almost 1/3 of deaths where it was either nursing home residents and or related staff. And I know here, at least in Sangamon County, 80 of our 150 cases are from one nursing home. And so there is a definite issue at one of our nursing homes here in the county where they cannot get it under control at all. And it's bad enough that it's starting to leak into the community a little bit. Someone wanted to thank us for that they got their golf back. You know, that's good. I'm glad we could help out with that. Someone said they called the White House regarding the status, and the whole time is typically only 25 minutes to speak to a human. So very good experience from calling. Okay, so that's good. So definitely reach out to the White House. The more that we're calling and letting people know that we have issues going on, specifically on DIR, the more that they know, the better. Someone said reimbursement for tests. Starlin saying reimbursement for testing is still being established. That's true. I've actually got a document. Well, I can't show it up on who it is from right just yet. That is going to be on payment and trying to find ways of doing it. I'm hoping we can avoid the PBM route, but right now that almost seems the easier route, the path of least resistance. But if we do, we're going to have to make sure we don't get messed over. Medicare is paying the primary care providers in the labs in states they have provider status. IPHA and NASPA are working on the testing reimbursement, and I'm actually part of the payers group for NASPA. Shane says, I'm too interested in reimbursement for testing services. We have 3 CLIA waiver pharmacies as of this week, awaiting guidance. Hopefully we can get you guidance here pretty soon. A lot of this is starting to come together pretty quickly. And Charlotte says, yes, that's what she heard her say on the press conference, which is good. I thought that's what I heard her say this week too. And I'm really glad some of you may have saw that at the White House this week, a number of the major chains were available to that said that they were going to be helping with COVID-19 testing. I'm glad they were able to do that, but it doesn't help the rest of us because they get access, through this partnership, they're getting access to tests and the supplies from the government. And so therefore they're not losing any money, but they're not gaining any money. And I'm sure there is going to be some type of transfer. They're not going to do all this for free, but it's still going to be you got this, you got that, and it's probably going to be like, Starlin said, a block grant. And that's good, but that doesn't establish a true process. It would have been great if we could have stepped out of those conversations with a true process that made pharmacists providers and helped establish the entire profession instead of looking out just for the company's best interest so they look good on a press conference. So I'm glad that they did this, but it doesn't help the profession overall just yet. What percentage of positives work at meatpacking plants? That for Illinois, I don't know. I know that there was one plant here that they were taking a look at, but I don't think it is near what we've seen in other places. But again, we really need to make sure that we're working, encouraging all of our patients to be wearing face masks when they're out in the public. Anybody have a question or want to raise their hand to talk? We do have a couple minutes left. I see we're still holding about 40, but before I let you go, I want to throw up a poll. I want to try to do a poll here. We've been doing these now weekly for 6 weeks. And Hank, I'll go to you here real quick. Go right ahead, Hank.
Did you say that Jan Schakowsky was with us on the DIR?
She has not signed on. She's been with us on letters in the past, but she has not signed on to the current letter.
Okay, thank you.
No problem. I know we've been holding these town halls weekly now for 6 weeks, and we're still holding strong at 40. I know we've been up as high as 70 in this, and I just want to make sure we're not fatiguing you every week, and it's not letting me do the test. Why is this not letting me? It's well, anyway, we'll send out a poll to everyone through SurveyMonkey. I was hoping to do an instant poll here, but it's not allowing me to do it. I wanted to get some feedback, and if you guys want to type it in there now, whether we should do this as weekly or every 2 weeks. I do not have a problem with continuing them weekly, but I want to make sure we're hitting your interests in what you guys are feeling. Greece said the Belleville News Democrat reported today that half of the COVID deaths are long-term care, at least in the county. Oh my goodness. In St. Clair County, so it's down the Metro East. Wow. Someone's asking, what specifically should we state to the White House regarding the issue over Grogan? If you do contact the White House, just talk specifically about how DIR fees are strategically damaging independent pharmacies and just community pharmacies as a whole, and talk about how this, it was a danger point and a pressure point before COVID-19, and now it is a death spike into the hearts of pharmacy. And if we need to make sure that we're ensuring access to pharmacies and healthcare providers, this is the time that we need access to all healthcare providers as much as possible. And we already have enough pharmacy deserts in Illinois that already show big holes where we don't have pharmacy access. And we have a number of counties throughout the state that pharmacies are the only healthcare provider that is available to our citizens. And we need to make sure that we're doing everything we can to keep that access open. And I see some of you are putting in your comments about weekly or bi-weekly, and that's good. Again, if any of you guys have any other questions, I know you guys are putting in comments on the weeklies or bi-weeklies, so I really appreciate that. Oh. Go ahead, Rupesh.
Well, can we create like a standardized statement like NCPA had, whereby we can send it to our congressmen who are not participating? We can share it with everybody where it's auto-filled, where they just put their information and we can submit it straight to their office. Is there something like that that can be created through IPHA?
I can take a look at that. We don't have a service like that where our members can just type it in and do that. We're looking at that. I've been trying to find one that's fiscally responsible for the association, but we at least can get some type of base message that people can copy and paste and email to their or send off to their congressman. But we're looking at that, like Voter Voice and some of these others. They're very expensive, but we do want to make sure. I think they do offer some value. Some of them are starting to come down because of situations like this, and I think that there's ways that we can take a look at that. But either way, we'll get a message out through a farm flash to everyone here, and hopefully I can get out tomorrow, Friday. And I do know that Friday there is supposed to be a letter going out to all members of the House from the state pharmacy associations as a joint letter on the DIR effort. So we're finishing that, and that's being coordinated through NCPA and NACDS jointly. All right, at least most of what I'm seeing here is seeing everyone says weekly is good. So we'll keep going weekly. We're working with our Public Professional Affairs Committee right now to work on topics, and I think we've got some other topics that'll be coming in addition to what we've had. I think we've had some very lively discussions over the last number of weeks. I do want to encourage everyone to continue to be active and talk. This is a discussion in your time. And, oh, Phil, I saw your hand up. Hang on one second. Go right ahead, Phil. Oh, hang on. Well, Phil, it's not letting me unmute you. So if you want to raise your hand again here, or you want to type your question in. Oh, hang on a second.
Am I there now?
There we go, Phil. I can hear you. Go for it.
Okay. Just want to get back to your request for etiquette. Those of us that signed on early, and Starlin can attest to this, we heard a tirade laced with profanity before you came on and muted everybody. So please, when you sign on, mute your microphones, or possibly, Garth, if you can have it set up to mute automatically as we sign in.
All right, we'll definitely take a look at that. We're sorry we had that technical grammar issue at the very beginning, and I do appreciate you making us aware of that. Thank you.
So please mute your mics when you sign in.
That's right. Thank you.
Garth,
Yes.
Shane had a question about the, go back up, about the meat packing plants. I don't know that yet. I think they're still tracking that.
I don't either. I know that there is an issue with a meat packing plant here in the state, but I don't know what the status is. I remember seeing it somewhere, and we'll have to take a look at that. I do know it's a definitely major issue. To me, meat packing plants, just like grocery stores, you got to be very careful how close they all are to each other, and it's hard whenever you're in work environments, just like it is in a pharmacy. It's hard to maintain that 6 feet of social distancing, and we've got to do everything that we can to make sure that we're protecting ourselves and our employees. Oh no, Shane, I agree with you. It is definitely a public health cascade. I think we can see that up in Sherman and Sangamon County right now, where we have this, this one nursing home that's got over 80 cases, and it's already impacted one of the convenience stores that is very near there, that it's also closed down now. So the issues going on in that facility is starting to leak out into the community as a whole, and that's just going to continue to spread until they can get a quarantine and a stability in that nursing home. So it's a very good point. All right. Well, I think we'll wrap it up here for this week. I do want to thank everyone again for your time. And again, be safe out there, and we'll see everyone next week.